Welcome to week 2, module 2, lesson 3, and we begin here a series of 3 lessons talking about the Cures Act of 2016. The Cures Act, which was passed, excuse me, which was passed by Congress on December 13th, 2016, and referred to simply as the Cures Act. That's how we'll refer to it. Had several high-level intentions to promote and fund the acceleration of research into preventing and curing serious illness, to accelerate drug and medical device development, to attempt to address the opioid abuse crisis specifically called out, and tries to improve mental health service delivery. So this is the 3rd time we've seen a mental health focused bill from Congress. The 2008 Mental Health Parity and Equity Act, the 2014 Excellence in Mental Health Act, and now here again, it's a core feature of the 21st Century Cures Act in 2016. I've read people describe this as the most important legislation for mental health in the last 50 years, which is an interesting comment because I'm not sure what they would have had before the last 50 years, but we'll leave that. Sorry, bit of a frog as I talk through all of these lectures. And finally, when we look at the overview of the Cures Act, it included a number of provisions that push for greater interoperability, adoption of electronic health records, and support for human services programs. I have to tell you, I'm still not quite sure what that support for human services programs were. And notice that consumer health informatics as such was not expressly called out, but you'll see that it has a huge impact on the opportunity and the requirements for the 21st Century Cures Act. And also, as you'll see, there was a lot more that's in this. It's an amazing accomplishment, this Cures Act. Some specific areas of focus. The bill is largely known to help fund efforts like precision medicine. Might be an interesting homework assignment. What is precision medicine? What is the relationship between precision medicine and consumer health informatics? I think, in my understanding, precision medicine is more about the idea that with genetic improvements, with the kinds of technologies broadly, we can tailor the therapies and the treatments to each individual more precisely than we have in the past. Focus on improving quality of care for patients. Excuse me. Improving the quality of care with interoperability as the main concern. Strong emphasis on providing patients access to their electronic health records that is easy to understand, secure, and updated automatically. In there, the notion of consumer health informatics pervades that whole topic area. And the bill also instructed the ONC, once again, back from 2004, to work with the National Institute of Standards and Technology, NIST, and other agencies to ensure full network-to-network exchange of health information. There's that HIE focus. But remember, the HIE is not purely, in this world, a focus on provider to provider, but also, or provider to payer, but also provider and payer to consumer. They're mandating it, although it's not apparent on the surface. When you look at the detail underneath, this is the key, that they are mandating interoperability with consumer health informatics when it's not already baked into, for example, an electronic health record. Also sets up a provider directory that allows consumers to choose and to evaluate their providers for how well they're doing with this evolution. And it was tasked with educating healthcare providers on the ways to leverage these capabilities of health information exchange and to clarify any misunderstandings. So it's still not the full force I would like to see for consumer health informatics, but it's implied. It's clearly implicit in all of these steps. This is one of two. Let's look at two of two. The first mental health reform bill in more than 50 years. I guess they did not consider either the 2008 or the 2014 to be significant mental health reform bills, but they set the stage for this. It also calls for a revised understanding clarification of HIPAA regarding permissible practices. Now, the HIPAA, the Health Information Portability and Accountability Act, is another piece that fits within that Affordable Care Act discussion and high tech. HIPAA, and I should have probably called that out on my map. Among the things it talks about is the privacy protections that must be afforded, for example, to any patient, but particularly anticipating addiction and mental illness, saying that you can't just disclose that someone is on severe antidepressants, even if that might be of importance to someone diagnosing that person and prescribing other medications to deal with pain or such activities, such needs. And so HIPAA kind of posed a conflict. When patients suffer from drug addiction or mental health issues, the privacy rule of HIPAA may hinder the appropriate communication of healthcare information or treatment preferences with appropriate caregivers. So the Cures Act tried to unsort or to sort out that conflict and say, yes, we want to respect privacy, but we also need to make sure that in order to deliver the best care, we must share that information in certain cases for certain reasons. And that will beg a whole host of issues through the course of the semester on what is the role of the patient to moderate, to dictate, to determine who gets to see what information. And finally, the provisions of the Act are specific to patients who are mentally or physically unable to make their own decisions. So rather than saying it's the patient only, it elevated the role of caregivers, family, as a participant, as a stakeholder overall. Now, there's a lot more going on in the Cures Act. One area we're going to talk about, not so much today, but as we move down the road, is the changing roles with respect to the FDA, and how does the FDA deal with approving particularly consumer health informatics. So the Cures Act is of huge importance to us. Now, based on the Cures Act, this comes from Cornell, and it's what they call a new paradigm for healthcare, the connected patient, pursuant to the Cures Act. Again, they didn't call it out and say this is because of the Cure Act. They said, in light of the Cures Act, here's how the connected patient would look. I have a few problems with this particular rendering. Under the consumer patient, they show all kinds of things which are really about passive remote monitoring, which is just one form of consumer health information. Wearable biometrics, tracking, medication reminders, BP, heart rate, communication with providers, control and monitoring of auxiliary health information. That's a good start, but I think there's a lot more that we'll explore. And then from there, it includes then the patient in the connected health in what is the larger universe, the health information exchange network, with the health record, with the providers themselves, with caregivers as stakeholders, with researchers, developers, and certainly with payers, and to the degree appropriate, employers. Part two, it's when we talk about connected health and we go beyond just what they listed, certainly remote patient monitoring has to be there. There was a movement called the quantified self, where people were investing in technologies that would help track all of their health-related behaviors. I haven't heard that term as much lately. It was a freely spinning wheel in that quantified self movement, I did not see it incorporated into the healthcare technology ecosystem, but they were standalone applications that someone could print off information and show the physician that says, this is how I behave, this is what I do. So it's a step in that direction. We also have a lot of surveys and status queries. I've developed a number of those related to addiction, criminal justice reentry and certain mental health related solutions, where you are providing the least disruptive way of asking patients, how are you doing today? How are things going? And providing them encouragement to maintain behaviors. I'll tell you more about that, I'm sure, as we go. We also have digital therapeutics. And finally, my favorite, software as a medical device. Those last two, I'm not fully sure in 10 words or less how best to describe them, but we certainly are going to explore those last two, and beginning, I believe, next week when we start to look at evidence-based practice. But see the trend, and we could also put information gathering as the first one, and we could add a few other things to this too. But when you say things like peer support or policy advocacy, those are less part of the connected patient. They may be consumer health informatics related applications, but I don't call them part of the connected patient, because policy advocacy may not lead to that, because peer support may not lead to part of the network as a whole. Research certainly could be here as another dimension of it, and we'll talk about that when we talk about evidence-based practice. So when we are thinking about this, physical health, mental health and addiction, social determinants of health, another area that we'll be looking at certainly, diversity, equity, and inclusion, DEI. That is helping us to ask the question, how can, the Cures Act says, we need to think in terms of technologies that better reflect each of these categories. Social determinants of health means housing, food, employment. Do you live in a neighborhood that is safe? How do you struggle just to get by many times? What are the social influences around you? Criminal justice relationships. Diversity, equity, and inclusion says, are we communicating with the patient in the way that allows them to benefit given their social heritage, cultural experience? These are called out in the Cures Act, and each of which poses an incredible opportunity. Well, each of which, particularly the last two, really all of them, all provide opportunities for consumer health informatics. And underneath this, let me introduce now the United States Core Data for Interoperability, or USCDI. As a part of the Cures Act, or extending from the Cures Act, this is an attempt to go beyond the old CCD and CCDA, although they may still apply. The CCD may still be a summary format of the elements to include. The CCDA still applies in terms of the structure. This goes further and says, what are the elements that need to be included across a range of these things, across all of the topics? And so we will explore, and that'll be part of our assignment, is to understand how the USCDI applies, and does it apply? Does it give us guidance that relates to what we're doing with consumer health informatics? What should we include? What shouldn't we? What is a standard-based element, required element, perhaps if you're covering an area, and what is additional information? Those are determined by USCDI. Some other considerations. As we've said, we're now focused much more heavily on risk-based compensation models, where the provider carries part of the risk. I'm going to build this page out and then come back to that one for a moment. Harmonized compensation models. A present push on the most recent plan to implement the Cures Act says that rather than having this payment for Medicare, that payment model for Medicaid, which is state determined, employer-based payment models for something else, Veterans Administration for something else, and providers having to figure out how to manage these completely different universes, the Cures Act and the subsequent roadmaps right now in this past 6 months have really begun to focus on, we want you to harmonize your payment models. We encourage you to do that, and that they should be risk-based. And that means if you can say, I've worked out a really good payment model for the services I want to deliver with Humana or Blue Cross Blue Shield or Kaiser Permanente, any of the major private organizations, because these private organizations not only represent employers, they also are the representative for most Medicaid organizations. So they can harmonize through that, both the state Medicaid plans, hopefully, and the employers and private plans. And what this says is we encourage Medicare or the VA, we encourage all of it to begin to harmonize, if not the specific payment models. VA, Veterans Administration for our armed services, for example, don't have the same payment model per se, but they do want to use the same incentives, the same measures of success. It's harmonizing these to simplify the universe for providers and to ensure an overall improvement. Information blocking, that gets back to the question we talked about earlier, reconciling HIPAA with the needs of a more robust health information exchange and engaging consumers. Information blocking, which we're going to explore shortly, is the next topic of how do we determine what information should be made available and under what circumstances. And then finally, something called, sorry, the Fast Health Interoperability Resources, or FHIR. These are the standards themselves for exchanging information that is a part of the USDCI standard that we just talked about, and also includes the capability of extending information. This becomes the building block on which we exchange information regardless of each whatever system it is. And we're going to look at that more closely in a minute. So last couple of comments here. Regarding patient experience in particular, the Cures Act requires more transparent. Now, this is interesting. This comes under the heading of patient experience data, but is really only one small aspect of consumer health informatics. Section 3001 of the Cure Act says it will create, that we need to create, under the heading, patient experience data, more transparency as to how patient information is being considered as part of medical product review process. That relates to the Food and Drug Administration's approval of new medications, treatments, therapies, and I would go beyond that to say, and more broadly, evidence-based practice, and saying we have to do a better job of including patient experience on an ongoing basis. That we have to not just do a trial over here and say, that looks good to us, we've run these tests, now let's put the product out there and it's off and running. Now we really have to find ways to capture and maintain patient experience data over time. For us focused on consumer health informatics, I would like you to put a big red star next to this. This is an important opportunity that is, if not an end, that is to say, not a primary goal, it is certainly a goal that can be leveraged in the design of what we're doing. Sometimes you support one objective for the purpose of achieving the right to pursue multiple objectives. This may well be one of those. The other is Section 3002, patient-focused drug development guidance. It seeks to provide clearer direction and guidance to stakeholders interested in developing patient engagement tools, including direction and guidance on processes and standards for producing instruments appropriate for regulatory review. This is the section that leads to regulation that says, if you're going to offer a new consumer health informatics platform, here's how you know whether you have to get FDA approval at all, whether it's a covered technology or is it just something else? And if it's a covered technology, how do you get your software application or your software, hardware, other device application through the FDA process? How do you understand it? How do you get through it? Hopefully, how do you make it less daunting? So these two provisions, without constraining the universe of consumer health information technology and consumer health informatics, are two linchpins that we must always, when we design our work and think about something else, ask ourselves, how do we fit into 3001 and 3002? Well, boy, oh boy, let's see, the runway. There's one last thing I want to talk about in this early stage about the Cures Act. As you may know, we had our midterm election last November. And the result of that was that the United States Senate stays controlled barely by the Democrats, and the House of Representatives shifted slightly to the Republicans by a few votes. And of course, that the White House, the third branch of the government, the executive branch, is controlled by a Democrat. That's, from our view, a really big deal. What that means is that the policies around the Cures Act, implemented particularly during the first couple of years of the President Biden administration, those rules which have been promulgated in the last 2 years, 3 years, aren't going to change. Because even with a slightly Republican House of Representatives, even if they want to make all kinds of changes, they aren't going to get there because the Democrats will thwart it. And if the Democrats in the Senate, rather, don't thwart it, the Democrat in the White House will, and there simply isn't enough horsepower on the Republican side to change that. From our view, the practical implication is really simple. It means we have 2 to 3 years, I'll say 3 years, between not only the next election, but the first year after that for that administration to settle in, during which we know pretty much what the landscape's going to look like. It's not going to radically change. We're already on a course. We're going to stay on that course at least 3 years. We might stay on that after that, depending on what happens in the elections of 2024, or we might begin to see it unravel. So, or at least change in priorities. So the important thing for us is now's the time to run. And for you as HIT professionals, know that as you're working with your employers or vendors, this is the time to not be shy. And this runway in this world is a relatively long time to work with a knowingly stable environment. And that concludes our first discussion on the Cures Act. Next, we'll talk about information blocking in lesson 4.